Hi, my name is Megan Chory. I'm going to be doing my cumulative skills video for advanced nursing skills. My simulation patient is Jane Dickinson. She's here for a bowel obstruction. She has a history of cancer and is receiving chemotherapy. And I just received some new orders from the doc. We're going to do a 500 milliliter bolus for her low blood pressure. We're going to give some IV push Zofran because she's complaining of nausea. And then we're also going to get an NG tube inserted and hook that up to LIS just to help empty the stomach. So I'm going to go ahead and get started. I already have a TKO line running. That was in the orders. So there's 0.9 normal saline hanging up there going at 10 milliliters an hour right now. And then the patient also has 2 liters of oxygen running via her nasal cannula per physician orders as well. So I'm going to head on into the room and we're going to meet Jane. Hi, Jane. How are you doing today? Good. Okay. I'm just going to wash my hands, provide for privacy. My name's Megan. I'm going to be your nurse today. Can you just verify your name and date of birth for me? She says Jane Dickinson, 3/24/33. Okay, perfect. Thank you. So today, I hear you've been feeling a little bit nauseous, huh? She says, yep. So we're going to take care of that. I got an order for some Zofran, which is some medication that's going to help you feel a little bit less nauseous. We're going to give that to you through your IV. And I'm also going to give you some fluids through that IV as well. That's going to kind of help boost up your blood pressure, which was a little low. And then I also have to insert a tube into your nose, and that's just going to help us empty out your belly. That's going to make sure that your tummy has time to heal after this bowel obstruction, okay? She expresses understanding and says that she'll do her best to cooperate with me throughout. I checked her allergies with the chart, and then she confirmed as well that she is allergic to betadine and codeine. But I won't be using either of those things today, so we don't have to worry about any allergies. So I'm going to go ahead and get the bolus started right away because we want to make sure that we're getting her blood pressure up. So I've already identified my client, checked for allergies, washed my hands and all that jazz. And then I didn't need any additional supplies for this bolus since she already has saline hanging up here going at TKO. I am just going to use that same bag because it's only a 500 milliliter bolus. Then I don't have to reprime anything. I can just use the saline that's in the bag. So this IV is already infusing, but I would want to make sure that I'm assessing for tenderness, redness, signs of infiltration. Jane says it feels just fine, and my assessment is all within normal limits. So I'm just going to go ahead and use this IV site. So I'm just going to change my rate and my volume according to my math. But first I just need to do my checks, my 5 checks 3 times. So I have 0.9 normal saline, 0.9 normal saline, 500 ml bolus, 500 ml bolus for Jane Dickinson. And this is just a one-time order through her IV. And we're going to infuse this at 166.7 milliliters an hour. So 0.9 normal saline, 0.9 normal saline, 500 milliliters, 500 milliliters. Due now. It's just a one-time order, and we're going to give this over 3 hours. So we have Jane Dickinson, 0.9 normal saline, 500 mils, 0.9 normal saline, 500 mils. And we're going to infuse this over 3 hours. At a rate of 166.7 milliliters per hour. So now that my 3 checks are all done and my IV site is assessed, I can go ahead and program my pump. So I'm going to change my rate to 166.7, and then I'm going to change my volume to 500 milliliters. Okay, and then here's my math that I used to calculate the rate. And then I'm just going to bring you over here to the IV pole. That way you can see that I have programmed the pump correctly. correctly. Okay. So now that I have that bolus started, just gonna want to remember a few lifespan considerations. Need to remember that my patient's going to be hooked up to this line for 3 hours now. So I'm going to want to implement false precautions and make sure that she understands that she needs to call me if she wants to get up and go to the bathroom. This IV line now is a tripping hazard, so I want to make sure that my patient stays safe. And then if I'm dealing with somebody who I think is already a little bit fluid overloaded, or I should do a baseline lung assessment just to be sure that I have something to compare it to after this bolus is done. Then we can listen to lung sounds again and just kind of keep track of our progress. So those are a couple different lifespan considerations that we can do. So I'll kind of clean up my supplies from that skills. Like I said, I didn't really have to bring in any extra supplies since the normal saline was already hanging. And then we'll move on to that IV Zofran. So, I already checked my patient's chart for allergies, so we're good there. And I'm in order to give 4 milligrams of Zofran IV push every 8 hours PRN. So she has not had this in the last 8 hours, so I am due to give this again. And I'm just going to go ahead and get this, do my math and get this dose accurate right away. So I'll come over there. I'm just going to get this dose accurate and then I'll come show you. Okay. So here's my math for the Zofran. I'm going to be giving 1.3 milliliters or 4 milligrams. And then here's my syringe. I have ondansetron or Zofran. It's not expired. And it's 6 milligrams per 2 milliliters. So that gives me my 1.3 milliliters. I don't know if you can see that there. Okay. So now that I am dose accurate, I want to do my 5 rates 3 times. So I have 1.3 milliliters of Zofran here. Okay, so I have Jane Dickinson, 324.33, 324.33, Zofran 4 milligrams IV push. She has not had this in the last 8 hours, and I have 1.3 milliliters here, which is my 4 milligrams. Okay, so Zofran, 4 milligrams IV push, which is 1.3 milliliters. I have 1.3 milliliters here. We're doing this through her existing line that is running, so I won't need any flushes or anything. This is not expired. So I have 4 milligrams Zofran, 4 milligrams of Zofran for Jane Dickinson every 8 hours, PRN, and she has not had it in the last 8 hours. So I have ondansetron or Zofran, 1.3 milliliters, which equals 4 milligrams, and we're giving this IV push. Okay, so now that I have done my checks and I'm certain that I have the correct dose, I am just going to go ahead and I'll wash my hands, put some clean gloves on, and then I'm just going to assess that IV site again. Even though there's something running already, I just want to make sure I'm keeping an eye on it so it doesn't look infiltrated or anything, and I can infuse right through this bottom port. So I'm going to take my alcohol prep pad and my medication. Now, since this line is already running with normal saline, I have checked compatibility, and it is compatible with normal saline. This does not need to be diluted, and it should be given over a rate. The Betty book says at least 30 seconds, preferably 2 to 5 minutes. So we'll just go 2 to 5 minutes just to be safe. So I've checked the Betty book. It's not expired. I'm giving it over 2 to 5 minutes. I want to make sure my patient knows. So Jane, this medication, it should help resolve your nausea, but it also may make you feel a little bit drowsy, a little bit lightheaded. So we're just going to make sure we keep an eye on that, but I want you to let me know if you feel lightheaded or drowsy at all, okay? And she expresses understanding. I need you to hold nice and still for me while I inject this so I don't accidentally take your IV out. And she expresses understanding that she can cooperate. I don't need another nurse in here. So I'm just going to clean off my hub with my alcohol prep for, I want to kind of forcefully scrub that for at least 15 seconds or per facility protocol. And we'll throw that in the trash. And then using like the no touch technique, now that I've cleaned this port, I want to make sure not to touch it. Just going to hook up my syringe here. And I'm going to instill the medication over 2 to 5 minutes. So nice and slow, nice and slow. And just for time purposes with this video, we're going to say that it's been 2 to 5 minutes, just because I don't have all day to tape. So, okay, Jane, is your IV still feeling okay? Okay, excellent. That's great. Perfect. Okay, so I'll be checking in with you to see how your nausea is doing. So try to pay attention to that for me. Some lifespan considerations. If this person is elderly or maybe has a history of renal failure, I could instill it even slower, just to kind of protect them. And then I also want to make sure that, if they're a little bit delirious or moving around a lot, if I need an extra nurse in here to help me hold the arm or the extremity that the line is in, I should do that, just because, if I have this syringe hooked up and I'm trying to slowly push it and this patient's flailing all over the place, my chances of ripping out my IV or not instilling the medication at the prescribed rate are pretty high. So just want to make sure I'm being careful with that and grabbing any help if I need it. So that skill is completed then, and then we're going to move on to the NG tube insertion. So I'm just going to take my gloves off, wash my hands, put a new pair on. Okay, Jane, next up we're going to have to put that tube in your nose, okay? And she says that she's had one before. Last time she had a bowel obstruction. So she feels like she's able to hold still for me. And she's not looking forward to the procedure, but she knows what to expect since she's had one before. So I feel comfortable doing this skill by myself with her. I'm just going to assess her lung sounds before I start this, just because I want to make sure that I have a baseline to compare things to. Sometimes NG tubes can go into the lungs instead of down the esophagus and into the stomach, so I just want to make sure that I'm kind of keeping track of all these things that Miss Jane has going on. So I'm going to just measure first. We're going to start, this will tell me how far I need to insert my NG tube. This is like a rough estimation. So I'm going to go from the nose to the ear with my tape measure, and then down below the xiphoid process. And I'm going to make a mark on my NG tube so I know when to stop inserting. So I'm just going to put a little piece of tape on there so I know how far to insert, and that is perfect. And then I am also going to take a look at Miss Jane's nose and figure out which nair is going to be the best for us to use to insert. So she does have a nasal cannula. She has 2 liters nasal cannula going through her nasal cannula. So I'm actually just going to scoot this over into her mouth. That way it's kind of out of my way, but she's still getting the oxygen that she needs. She's kind of a mouth breather anyways, and just gonna make sure that I'm keeping an eye on her saturations while I do this, just to make sure that everything is all kosher. So I'm just gonna plug one side of her nose and have her breathe in just to see which has the better airflow. And I'm also just gonna kind of take a look back there, make sure I have a baseline of what everything looks like. So it looks like her left nair has the most airflow through it, so that's going to be the nair that I'm going to use. And then I want to make sure I have an emesis basin close by in case my patient feels like she needs to vomit. I would have her normally sitting up in high Fowlers, or if this was a real patient in the clinical setting, but these mannequins can't be sat up further than a semi-Fowlers position, so that's why it looks so much lower, but I would want to have her up to at least high Fowlers when I'm doing an NG tube insertion. So just for this SIM patient's restrictions, we're going to have her a little normal than we usually would, or a little lower than we normally would. So I have my pad here to protect from any spillage. And then I have her nasal cannula out of my way. I'm just going to wash my hands, change my gloves, and then I'm going to put the tip of my NG tube in the lube just to kind of make it pass through easier. And then I'm going to open up my tongue depressor too. That way when I'm inserting the tube, I can make sure that the tube does in fact go down the back of the throat and it's not coiling up in the mouth. This will just help me kind of visualize some things. So I'm going to go ahead and put some skin prep on Jane's nose. Okay. And then change my gloves. And then, so I actually already have the syringe hooked up to the end of this, just because when I do hit the stomach, some stomach contents might start squirting out the bottom. So if I have that there, it'll kind of collect into there instead of squirting all over. It's just going to kind of save me a little bit of a mess. Okay, Jane, so while we do this, she's NPO, so I'm not going to be able to have her swallow, which is usually a helpful intervention to kind of help pass through that oral pharynx, but since she's NPO, we're just going to have to use the head tilt methods, and then I'll instruct her to swallow instead. So we're going to start with her tipping her head back. Okay, Jane, you can tip your head back. And I'm going to insert through my left nair. Okay, you're going to feel some discomfort. Try to sit still for me, okay? And we're going to just kind of pass that tube. And I'm going to make sure that I'm watching in here to make sure that it's passing correctly. And it's not coiling up in the mouth. Okay, now you can tilt your head down and swallow, Jane. Swallow. Keep swallowing. Keep swallowing. Okay, and I see my tube back there. So that's good. And I shouldn't ever let go of this tube. So I'm just going to insert this. So that is, I'm going to stop at my point at which I measured before. So I'm at the correct point here. That's what I measured with the tape measure. So I'm just going to secure this with my piece of split tape. How are you doing, Jane? Good. You did a great job. I know that's no fun, but you did excellent. And then I'm just going to put the nasal cannula back in her nose. Nostrils can feel a little bit full with a nasal cannula and an NG, so you can switch it over to either the empty nostril or you could use like an oxy mask or something instead. Jane, does this feel okay the way that I have it positioned? And she says it does, so I'll just leave it. I'll leave it in her nose. So before I hook this NG up to suction, I want to make sure that I've verified placement first. So it kind of differs depending on what facility you work for, but most facilities require that an NG tube be confirmed by a chest x-ray before it can be used. Some other ways that you could do it are testing the pH of the of the contents. That'll tell you if you're dealing with stomach acid or not. Otherwise, you could also instill a tiny bit of air through the NG tube and listen to the stomach with a stethoscope for bubbling. That's another way that you do it, but definitely the most definitive way to know if it's placed correctly is going to be chest x-ray, and that's what most places require now. So we're just going to say that chest x-ray came already, doc approved placement, said it's ready to go. And we need to get Jane hooked up to LIS so we can get her tummy emptied. So first, before I hook up the suction, I just want to make sure it's working. So I'm going to put it on continuous first, and then just check like the tandem port right here, and the suction is working. So I'll turn it to intermittent and put it on the low setting, which is what the doc prescribed for her. And I'm just going to kind of bend this so nothing comes out. We'll take the syringe off, and then we'll hook up the suction. And then we can just kind of position this right here by our patient. And another thing that's really helpful in preventing the tube from pulling, they're already so uncomfortable for our patients, so I'm going to try to kind of hook it up as tightly as we can. But I'm going to put this little piece of tape around the tube that has a safety pin on it, and then I'm going to just pin this right to her gown. So Jane, just be careful when you're kind of reaching towards your face, because you do have that tube there now, and we don't want it to accidentally get ripped out. So just be careful, and I have it pinned to your gown here so it doesn't move at all, okay? So I just kind of want you to be aware of that. She says she understands. Like I told you before, she's had an NG tube before, so she kind of is aware of how they work, but still want to make sure that I'm educating her. So she knows not to pull on the tube. If I had a patient that was a little bit more combative, rutsy, confused, maybe it's a pediatric client, I could talk about maybe doing a bridle to hold that NG tube in place, which is, a little piece that goes above the septum and prevents that tube from being pulled out. So that would be another option as well. Now I'll just kind of take a look at my patient's vitals, make sure that they're still doing okay. Jane, are you feeling okay? Yeah, your nose just hurts. Okay, how's your nausea? It's better? Okay, good to hear. I'm glad that that's improving. And looks like we still have a little bit of volume left on this bolus. The patient's blood pressure is improving though, so that's good. It means it's doing its job. Before I leave the room, I just want to make sure that I'm cleaning up all of my supplies. I want to dispose of all the trash. And then I'm going to want to document everything. So as far as the IV bolus goes, I'm going to want to document, all the med stuff, date, time, and my assessment findings. For the IV push medication, I also want to do date, time, assessment findings. So, for both of those things, that would include things like my site assessment, site of infusion, my lung sounds, and then how the patient tolerated or if the medication was effective. So in this case, her blood pressure did go up and her nausea subsided. So those two medications were effective, and that's great. And then as far as the NG tube, I'm going to want to document which nair I inserted it into, how far I inserted it. I want to document that placement was verified by chest x-ray, and that we are hooked up to LIS. Eventually I'm going to want to document output, but I just put it in, so we don't have any output to document yet. So I'll just make sure that Jane's bed is in the lowest position. She has her call light, her bed alarm's on. She knows not to get up without me. She's comfortable, doesn't need anything else. I'll take all my supplies out of the room, wash my hands, and I should be good to go.